Hey there, good evening everyone. Welcome to my new setup. I finally was able to get around to giving myself a nicer background and in a more climate controlled room. So I'm very happy to be with you tonight. Welcome back to I Care for Your Brain with me, neuropsychologist Dr. Karen Sullivan. We are here to try to meet the very significant unmet educational needs of the brain health community. We meet here on Wednesday evening, 6 o'clock Eastern Standard Time, to educate and empower through science-based information. My goal is to explain things to you in a way that you can really absorb and get, and then also guide you towards evidence-based recommendations that will actually make a substantial difference in your life. So every week we get together and we talk about something new. Today we were talking about a brain health challenge that is very near and dear to my heart. I love all the different communities that we have here on Facebook, but just through my own personal life experience, we are talking about Alzheimer's disease tonight, and that is kind of my special sweet spot. I have pretty much only worked in the dementia community. I had one other job one time in an ice cream store for a few weeks, and that only lasted a few weeks because my favorite band, Bon Jovi, came to town and I had to go to the concert. So if you've been involved with Alzheimer's in any way, you know that the experience leaves a profound impact on you. And that's really how I started my career as a teenager, was really that up close and personal understanding about what a neurodegenerative condition does to someone, does to them neurologically, does to them emotionally, their family, and also socially. So that's really remained my commitment to the brain health community, is to try to take a whole person approach. And I think it makes me a much better doctor because I have that kind of in the home, on the ground experience, and then also the academic experience that I need to be able to put all these things into good context for you all. In the comments, you're going to see a link to a short documentary about my journey. If you haven't seen it yet, I would really love you to take a deeper look inside kind of my commitment. And there's some really interesting footage in there we were able to unearth for me as a teenager when I was working in some dementia daycare units. So tonight I want to give you a brief description of what Alzheimer's is. I probably get more questions about what Alzheimer's is, what it isn't, compared to all the different things when I go out and do my brain health education talks. So what I really want to focus on is this new hope that we're having in the Alzheimer's world, that we really are getting closer than ever to what we call a disease-modifying intervention. Right now, the medications we have a couple, there's 5 that are approved by the FDA, and what they do at their best is they slow down symptoms. What we have all been waiting for is something that actually changes the disease course in the brain, and we're like this close. So I really wanted to help people appreciate that we're moving in a much more positive direction with Alzheimer's care. So we've come a really long way, right? We used to call it senility. We know it's not old timers anymore. It's not a normal part of aging. Alzheimer's is one of the dementia subtypes. So we've got a big old umbrella for dementia, and within that umbrella, we have multiple different subtypes of dementia. So as a neuropsychologist, what my job is to evaluate people and determine if they're going through any memory problems that are related just to normal aging, medical condition, medications, or do they meet criteria for dementia? Once you know it's dementia, then your job is, well, what subtype? And that personal evaluation is what leads to the personal recommendations that we all respect and want for ourselves and our loved ones. So to get a diagnosis of dementia, you have to have had a significant drop in your ability or your function in more than one cognitive area. So a cognitive area could be memory, it could be language, attention, visuospatial, problem solving, and it has to be to the level where it interferes with what we call your instrumental activities of daily living. So that's driving, remembering to take your medication, and the most sensitive area of all is money, complex finances, being able to balance a checkbook, remember and pay the bills appropriately, manage high-level investments, remember your passwords, all of those important things. There are 2 types of Alzheimer's disease. We have early onset and we have late onset. Early onset happens before you are 60 years old. I have unfortunately diagnosed people with Alzheimer's disease in their 30s and 40s. And in those cases, it's very genetic. So that's one thing, we all worry about, well, I have dementia in my family, what's my personal risk? A good rule of thumb is the younger the person is when they start to express their symptoms of dementia, the more likely it is genetic. So if you have a parent or a grandparent who started to lose their memory when they were in their late 80s, early 90s, that's not as worrisome as if you had a parent or a grandparent who had symptoms in their early 60s, in their late 50s. Those tend to be much more related to genetic issues. So when we think about Alzheimer's, let's of course think about risk factors. So age is the #1 risk factor. Now remember, it's not inevitable that you would get Alzheimer's just because you're older, but as we get older, that really is the most dictating demographic. So 3% of folks between 65 and 74 meet criteria for the disorder, 17% from age 75 to 84, and 32% of people 85 years or older meet criteria for Alzheimer's disease. For a long time, we thought that the very, very first symptom that was detectable was trouble with learning and short-term memory. So long-term memory stays super intact almost the whole way throughout the disease progression. And in fact, it's kind of a human need to be comforted by the past. It really speaks to our identity and gives us a sense of security about where we've been and where we're going. So long-term memories, when we have dementia, oftentimes become even more vibrant, even more comforting, and we can go over them time and time again because it gives us a sense of who we are in the world, what we're all about as people. But now what we know, that's actually not true. Memory is not the first symptom of Alzheimer's. What really happens for most people, and there's kind of a typical course of Alzheimer's and atypical, no one fits into a box, right? We're all different, complex people. But typically there's about a 1 to 2 year period before any cognitive symptoms show up that involve changes in mood and personality. And what people tell us is that this typically involves someone kind of retreating from the world, kind of a sense of going inside themselves, not as much spontaneity, not as much interest in things that they used to enjoy, less talking, just kind of more reserved. And this is concerning because it often mimics depression. And this is a great example of why we need neuropsychologists to do standard comprehensive evaluations on folks. Because think about the loss if we miss an opportunity to treat Alzheimer's early, because that's really the name of the game. We're going to talk about that more tonight. But also, we don't want to miss an opportunity. It also could be hearing loss. There's medical issues that make people kind of shut down and don't have enough mental energy to engage. So that's just another example of why it's really critical that we advocate for people we care about to go see a neuropsychologist. There's modifiable and non-modifiable risk factors for developing Alzheimer's. So non-modifiable ones are things you can't do anything about: your age, genetics, your family history. There's many, many more what we call modifiable risk factors. So what does that mean? That means you can actually do something about it. And in February, we're going to be launching an Eye Care for Your Brain, kind of like a brain university that is focused on these recommendations. They come from the World Health Organization about how to really reduce your risk of cognitive decline. Not the magic pills, not the video games, but really what do we know about how we can impact our behavior to better age our brain. That's very, very important to me. In the continuum of Alzheimer's disease, we have 3 broad phases. We have what we call preclinical Alzheimer's. We have mild cognitive impairment, which means you might have a decline in your memory or your language, but it's not that bad. And what's most important is you're still independent. You're still driving. You can still remember the meds. You still can manage the finances. All of that is intact, but maybe say the memory's gone down a little bit. That's mild cognitive impairment. Or then we can get into dementia, diagnosable dementia with Alzheimer's disease. Once we're in Alzheimer's, then the way I think about it is mild, moderate, and severe. I know some people like the stages. I think it's like 1 to 7 or 1 to 11. That starts to get a little bit too specific and not as helpful to me as kind of the classic mild, moderate, and severe. As the disease starts, for most people, it starts right here on both sides of the brain in an area we call the medial temporal lobe, and that's where we make new memories. That's why that symptom starts first. And what happens in Alzheimer's is slowly the disease progresses throughout the brain. And this is why we start to see more issues with word finding, disorientation, agitation, some of the more behavioral issues. So what is actually happening happening in those medial temporal lobes? Well, it's really related to an abnormal protein buildup in and around the different brain cells. So one of these proteins is called beta amyloid. These are deposits which form plaques when they kind of clump all together, like I said, around and in brain cells. And what can happen over time is they basically suffocate the brain cell and cut it off from all nutrients and all oxygen. And this is how we have brain cell death. And what you can visualize on an MRI is loss of tissue, brain atrophy in that specific reason. That's just one part of the puzzle in diagnosing someone with Alzheimer's, and not everyone has it. So it definitely is more complicated than I'm making it sound. There's one form of beta amyloid called beta amyloid 42 that is thought to be especially toxic in the brain. And so what's really interesting about Alzheimer's is as we get older, almost all of us have these plaques and tangles in the brain. What distinguishes folks who get Alzheimer's from people who don't get Alzheimer's is that the folks without Alzheimer's have a clearing out process that happens nightly, typically in deep REM sleep, in which I think of them like little garbage men. They go around and they cut up these plaques and tangles, and they have a system for getting them out. Unfortunately, in Alzheimer's disease, that system breaks down. We really don't know why. Plenty of people spend their entire career trying to focus on one little aspect of that, but we know it's just not happening. And it's really the buildup that interferes with neuron to neuron communication and ultimately kills the brain cell. So there's one other protein that's involved called tau. This is the one that gets caught within the brain cells. So over time, as we get more and more brain involvement, folks, as they go through the course of Alzheimer's disease, typically pass away from aspiration pneumonia. This is what my grandmother died from. This is when folks have some confusion at the basic brain level about how to swallow, difficulty coordinating those muscles as you have to send food down your food pipe. So what happens is the food goes down the trachea, which is the windpipe, instead of the esophagus, which is the food pipe, and particles get deposited in the lungs and cause a lung infection. That is the most common way folks pass away from Alzheimer's. So like all brain health conditions that we talk about here on I Care for Your Brain, I never want to reduce a brain condition to a medical phenomenon, because it's so much more than that. It's happening within a person who lives within a society, in a community, right? So these things are not just brain diseases. This is a condition that has a lot of stigma. There's a public health crisis related to Alzheimer's disease. It's a talk for another day, but I'm very passionate about pushing the agenda that the truth is folks with Alzheimer's disease tend to be ignored, talked over, disregarded, invalidated. And this is certainly one of the reasons we all fear it so much. Nobody wants to be objectified and become a non-person. So the way that I think about Alzheimer's is there's aspects that are very far from my expertise, the physiological lab-based stuff that all those smart people are working on. But the piece that I can support in my community is going around and talking about how to improve our treatment and our respect for people who are living with all brain health conditions, but especially something like Alzheimer's disease. It's certainly a public health issue as well. We've got the graying of America here with baby boomers finally getting to that age where dementia tends to be more common. And so I want you to kind of put that in perspective for a minute. So if we consider the causes of death in America, let's take the year 2000 here, and we've got the year 2018 here, okay? So when we do that comparison, in 2018, 8% of fewer people are dying by heart disease, right? So we've had a drop of 8% death from heart disease. 12% drop in death by stroke, 63% drop in death from HIV or AIDS, up 146% in Alzheimer's disease, okay? And a lot of that is just the age of the community, the age of the population. We have an absolute crisis in who is taking care of these people. Family members and friends provided about $244 billion in unpaid care to people with Alzheimer's just last year alone. Absolutely, I consider it to be a humanitarian crisis. If we had secret cameras in facilities that manage these people, I know we would see a lot of wonderful, beautiful, dedicated interactions, but I hate to tell you, I think you would see a lot more things that would break your heart and make you never ever want to go there. And we need to raise that standard. That cannot be acceptable in our society. So here's the good news, is like I was saying before, we have never ever been as close to a game changer in Alzheimer's as we are today. The president of the Alzheimer's Association recently called it a time of unprecedented optimism and momentum, which makes us also happy who care about this disease so very much. And really what's happening is we're finally bearing fruit on some trees that were planted in around 2010, 2011. In the United States, we had our first federal law that resulted in the first Alzheimer's disease plan. And what we did was we dramatically raised research dollars, grant money, to support Alzheimer's disease. So we went from about 500 million in 2012 to almost 3 billion for the fiscal year of 2020. That is really exciting because it's science and scientists that are going to bring us the answers. So we've known for a long time that in Alzheimer's, the earlier the better, right? Early intervention is key. By the time folks are 3 to 5 years into the cognitive issues and they come to see me as a neuropsychologist, there's been substantial brain damage that we just don't have strong enough drugs to reverse. That's just not something that exists today. So what we want to do is nip brain damage in as much of the bud as we possibly can. And the best way that you can get diagnosed at this point is through clinical evaluation, neuropsychological evaluation. But this is changing. So we are going to have a partner in the very, very near future where I believe we are going to be partnering cognitive paper and pencil evaluations with something called biomarker testing. And that is something I'm very excited about that I want to talk to you about tonight. So a critical concept within Alzheimer's, so nice to see all of you guys on here. The critical thing with Alzheimer's is you have to understand it's kind of like an iceberg. So the tip that you see when it first emerges is short-term memory loss, maybe some trouble with behavior, anxiety, but there's a whole big iceberg underneath the surface. So these statistics I think will blow your mind. So 20 to 30 years before the symptoms express themselves in a person, these plaques and tangles are not getting broken down and are building up in people's brain. 18 years before symptom onset, glucose is not being metabolized properly in different parts of people's brains. 13 years before symptom onset, we start to see brain atrophy, which means enough clumps of brain cells have died that we can actually visualize it on a scan. So this is the time we want to intervene. We don't want those plaques and tangles strangling the brain cells, right? We want to get in there as soon as possible. So this is where the biomarkers come in. This is how we get to look inside the brain of people and understand exactly what is going on to them at the brain level. This is the wave of the future for a lot of brain health conditions, but certainly AD. So this gives us that window to understand when things are starting and gives us an opportunity to intervene. Now, that sounds wonderful, but of course it's more complicated than that. So one complicating factor, and this is going to blow your mind, not everyone who has Alzheimer's disease at the brain level develops the clinical syndrome of Alzheimer's disease. 25% of folks have the plaques and tangles, don't have the memory problems. That is unbelievable, right? So that's the work of Yakov Stern out of New York University. He looked at autopsy studies and they had followed these people in life, and sure enough, 1 out of 4 had it in the brain, didn't express it. So that is related to all those modifiable risk factors. How can you make deposits in your brain bank every day so you could be one of those 1 in 4? That's part of the program we're going to do in February. So let's talk about the 2 most powerful biomarkers in Alzheimer's disease. One is relatively affordable and accessible, and the other one's very expensive. So the first one that is more affordable is a lumbar puncture, a cerebral spinal fluid tap, spinal tap, right? So this is, they put a needle between your 2 vertebrae and they take out a sample of the CSF, this fluid that surrounds your brain and your spinal cord. It's there to protect you from injury. It does some transportation for the immune system. It brings nutrients into the brain and it pulls things out of the brain, kind of that clearing out process. So what they do is they look at that fluid under a microscope. And here's what I thought was so interesting when I learned this. What would you think would be in that sample? If you were looking for Alzheimer's, right? Intuitively, before I really thought it through, I thought, well, they're going to find plaques and tangles in there because these people have more of them in their brain, right? Opposite. they find less beta amyloid because it's too busy clumping and sticking in the brain. It's not going anywhere, okay? So there's more of that amyloid getting released through the spinal fluid in someone without Alzheimer's than there is Alzheimer's. And it's a lot more complicated than that. There's a lot of other levels, but that in and of itself, I think, is very important. The other one is on a PET scan. So a PET scan is a brain image very similar to an MRI. And basically we can put radioactive tracers into the body through an IV, and it gets absorbed in the bloodstream and in the brain, and it attaches to certain kind of compounds. And so the people who develop these compounds are super geniuses, and there are people that have developed compounds that stick to this beta amyloid, these clumpy proteins. So we're actually able to show that 20 to 30 year process where it's building up in the brain. If you get diagnosed with Alzheimer's in the next 5 years, I guarantee you biomarker testing will be a part of what you do. So that's half of our problem, right? The early diagnosis. Well, of course, the big question is, well, what are you going to do about it, right? So where we're at now with treatment for Alzheimer's, I said before, we've got 5 approved drugs by the FDA. We've got donepezil, known as Aricept. We've got memantine, also known as Namenda. We have galantamine, and we have rivastigmine. And then we also have one combination pill, Namzaric, which is Aricept and memantine combined together. Except for memantine, these drugs temporarily improve cognitive symptoms by increasing the amount of chemicals called acetylcholine in the brain. With memantine, it's a little the opposite. They block receptors for excess stimulation related to the health of brain cells. The effectiveness of these drugs varies from person to person. They're pretty limited in duration. They kind of stabilize symptoms for a little bit longer than you would get if you didn't take it. And wouldn't you want to stabilize symptoms early, right? No, they're the best we have. I thank God for them every day. I'm so glad we have them. But none of these medications slow or stop the damage. Nothing as we have it now can stop the destruction of neurons that cause the symptoms and make this disease fatal. So what we're all waiting for is that disease modifying drug that actually does something. And we are going to see that in our lifetime. And I think that is the most tremendous brain health news I could possibly give you. So in the last few years, they've really focused on antibody trials. And I'm just going to tell you a little bit about those. I'll focus on it more in the next few months. But for right now, this involves injecting an antibody through an infusion in people at various time points, typically over about a year. And in about 2011, they started these, and it's taken 10 whole years and tons of money to get to the point where we are almost this close to getting word back from the FDA if this is something that will be approved. So we've done trials within mild cognitive impairment, within dementia, and we look forward to reading more of the research, but the idea is that we may have an opportunity to slow, not stop, but much more significantly slow the actual physiological process of Alzheimer's disease in the brain. We need to know, though, is it making meaningful changes in cognition? Does it help reduce the behavior symptoms? How does it affect people in everyday life? Can we get people more independent, right? What is the quality of life that we would be getting from such an intervention? There are about 121 experimental drug trials happening right now in Alzheimer's disease, and we've never had that many in the pipeline. Let's see, we have 29 right now that are in phase 3. That's really close to really finally getting to that human study where we can do the double-blind placebo control and really figure out what the actual impact is here. So while we wait for that cure that we all so desperately want, we need to improve the way that we treat these people. This is coming from need to change the way we communicate with folks with dementia, how to respect them. They kind of get a double whammy. They get the ageism of being older, and then they get kind of the brainism from maybe repeating themselves or not being able to remember people. But we always want to go back to the core. This is a disease that affects a person first, right, and a brain second. That's kind of the mantra of neuropsychologists. We have tremendous stigma about Alzheimer's disease. It's the worst thing that I diagnose in a given week because people have so much anxiety about it. And I'm not saying it's a walk in the park. I'm not saying there's no reason to be scared. I think, though, if we knew that we had models of care that were truly based on uplifting the human aspect of Alzheimer's, it wouldn't be so scary. And I don't think it would take the billions of dollars that we need for a medical cure to get better care for these folks. So that's something that's always on my mind. How can I be a part of that solution? So if you thought that this felt like a long one tonight. If this was helpful to you, I would really appreciate you spreading this information on Facebook. We're here because it's free and I can talk to so many of you at one time. I think this information is healing. If you have been affected by Alzheimer's, you are like me, you're over the moon that we're getting so close. It really will be a different experience, maybe even in 5 years from now, to get diagnosed with Alzheimer's, and that's pretty special. So if you join me next week, I'm going to be talking about something called freezing of gait, and this affects our folks in the movement neuropsychology disorder community. So we commonly think of it as associated with Parkinson's. So the definition of freezing is feeling that your feet are glued to the ground while walking, making a turn, or trying to initiate walking, starting to walk. But what I'm finding out from my folks in the orthostatic tremor community is they're going through this too. So I'm looking through the research right now to try to figure out if I can kind of pull the two bodies of literature together and help folks figure out, what do you do about freezing? Because I know it impacts fall risk and it's hand in hand with anxiety. Whether or not it's a chicken or an egg, I'll try to figure that out for you. But thank you so much for joining me here in my new cozy area here in my house. I think it's much better than where I was before. So thank you guys so much, and I hope you have a great week. I'll see you next time. Bye.